Hi guys, today we're going to talk about diabetes insipidus. The objectives for this topic is to just discuss and define, and you can find this information in your James book or your William Hopper book, and I provided the pages numbers for you. This condition is caused by the body having insufficient amounts of the ADH hormone that is produced by the hypothalamus and then stored and secreted by the posterior pituitary gland. If we lack this production, the body is unable to adequately reabsorb water through the kidneys, which causes deficient fluid volume and dehydration. This is a disease that affects fewer than 20,000 people, but it cannot manifest in a vast amounts of advanced stages. It is caused by a variety of different things like tumors and trauma, and it's also occur from inherited effects or acquired conditions. I thought this was a really good diagram to show you how ADH is produced, what it's used for, and how it affects our body. This just gives you a better description of why we need the hormone. You should really understand why diabetes mellitus is different from diabetes insipidus. Diabetes mellitus is characterized by high levels of sugar in the blood, while diabetes insipidus is a disease where they're unable to concentrate urine normally, leaving the result of large amount of diluted urine. There are 4 types of GI, which are neurogenic or central GI. Nephrogenic, where there is enough ADI that's being produced, but the kidneys are unresponsive to it. Typically, like the sensors are missing or defective. Usually, infants get it from inherited genetic mutations, while adults get it from medications or kidney disease. Gastrogenic DI is when the placenta makes an enzyme that destroys ADH, but the condition usually resolves after birth. And then you get these occurrences where it happens spontaneously for no reason, and this is called idiopathic. So the manifestations you see is a polyuria and nocturia, urine-specific gravity that is decreased, extreme thirst. They might be consuming a large amount of water, might be craving ice-cold water. Urine output exceeds fluid intake. You might see signs and symptoms of dehydration occurring. Maybe severe hypovolemic shock will occur, and enlarged bladder or kidney damage when constantly holding your urine in. I think this is a great diagram showing the history of how DI is caused and what are the signs and symptoms and nursing care. For diagnostic testing, we base it on history of risk factors and reported symptoms from the patient. We might see a urine-specific gravity that's less than 1.001. We might measure and compare plasma and urine osmolality, check sodium levels, do a CT or MRI to check for tumors in the pituitary gland, water deprivation tests, or glucose monitoring to rule out diabetes mellitus. The nursing diagnosis is deficient fluid volume related to failure of regulatory mechanisms, manifested by signs and symptoms of dehydration. The outcome that we want is fluid balance, which is evident by weight, intake, and output, and sodium levels within normal limits. It's important for hydration. We want to maintain elastic skin turgor, moist tongue and mucous membranes, explain the measures for treatment and prevent fluid volume loss, and to describe symptoms that indicate the need for consult of HCP. For the nursing process, we want to pay attention to the fluid balance. Usually that's by daily weight because it's reliable. We're going to do INOs, look for any possible dehydration symptoms and hypovolemic shock. We might measure for urine-specific gravity, assess the understanding of the disease and treatment with the patient, and if treatment is initiated, we want to monitor that fluid balance, but also be aware of any signs of fluid overload. For therapeutic measures, we're going to establish IV fluids immediately, like hypotonic IV fluids, where IV fluids are important if the patient is unable to take oral fluids. Then we're going to replace the ADH hormone, like vasopressin or desmopressin, depending on the doctor's order. Thiazide diuretics may be administered, If you have nephrogenic, we're going to place you on a low sodium diet and drink plenty of fluids. Drugs such as clomipramide can help the kidneys respond better to ADH. Pituitary tumor and removal of the pituitary gland is hypophysectomy. First nursing question. A patient with a history of diabetes insipidus arrives at the ER. What characteristics should the nurse be aware of for the client? Select all apply. Polyuria and nocturia, irritability, mental dullness or coma, hyperactivity related to excess sugar in the blood, or hypotension, poor skin turgor, or weakness. The answer is 1, 2, or 4. Because if urine output exceeds fluid intake, we might see dehydration symptoms, which are like the hypotension, weakness, and poor skin turgor. We also might see CNS manifestations. Number 3 is wrong because that is signs and symptoms of diabetes mellitus. Last question. What is the highest priority for the nurse to take when treating a patient with central diabetes insipidus? Start them on an insulin drip, IV fluids and hormonal replacement, low sodium diet and thiazide diuretics, or restrict fluid intake? The answer to this question is 2. IV fluids and hormonal replacement, because we want to maintain a fluid balance with this patient. We don't want them to become severely dehydrated and cause hypovolemic shock. And since this is where the patient was diagnosed with central diabetes insipidus, and that means they lack in the ADH production, we want to provide that hormonal replacement. Number 1 is wrong, is because that's an intervention for diabetes mellitus. Number 3 is wrong, is because our patient was not diagnosed with nephrogenic DI. And number 4 is wrong, is because we do not want to cause the patient to have severe dehydration and possible hypovolemic shock. We want them well balanced in fluid. Well, that's the end of my presentation. Thank you for listening.